Welcome to this edition of AFMC.
I'll tell you how I got better. I'm
Glad to be here.
But a mission to
Delivery of
improve.
I think that we're going to talk about everybody's.
Arkansas is the second highest prescriber.
Welcome to AFMC TV. I'm Robin Ledbetter. Thank you for joining us. Today I have with me Brittany Bradshaw. She's an RN and the Chronic Care Management Coordinator at Randy Walker's clinic in practice there in Sevier County in DeQueen. Brittany, thanks for being here today.
Hey, it's good to be here.
So can you start by giving us an overview of your role in chronic care management at Dr. Walker's clinic and the patient population that you serve?
Yes, so the population we serve right now is about 380 patients within our practice. With those patients, we consider high risk and we do home visits on them if they're not able to come into the clinic. You know, we monitor blood pressure. We do things in the home so that to keep the patients out of the hospital or from being readmitted to the hospital is what our goal is.
And for providers unfamiliar with rural chronic care outreach, how would you define the scope and purpose of chronic care management in a setting like DeQueen?
So, like I said, we do have a hospital here now. We just recently got one back. We haven't had one for a while. So we try to keep the patients in our area out of the hospital. If they need a home visit, we have a provider that goes out and sees people for home visits. If they need monitoring after that, blood pressure checks, their medication boxes filled so that they don't miss any of those. That's kind of where I fill in. I fill in the gaps where the providers need me. And basically I take it day by day, and whatever the patients need, I go out and do to keep them in their home and healthy and keep them out of the hospital.
And what clinical criteria or social determinants do you use to identify patients for chronic care management? Is it particularly those that are homebound or high risk?
Both. So we actually have screeners when they come into our clinic or when we go out and do a home visit on them. We screen those patients then, and we can tell if they need food, we give them food then in the clinic or in the home. We try to keep the bags with us if we do home visits, so they can have something right now. Then we also have resource guides that we give out to the patients with other resources like churches, things like that in our community that do things. And then we decide if they have trouble with transportation, we decide right then and kind of flag those patients, and they'll send me a referral or send me a message on our EMR, and we just kind of keep a list of those. Well, then I contact that patient after that, and we kind of get figure out where they are, a baseline, what they're going to need, and then go from there on treating them.
So you touched a little bit about the structure of your home visit program. Is this something to where you reach out to the patient? Is it like follow up, hey, we haven't seen you in the clinic? Or is this where they reach out to the clinic and say, I can't make it in, I need someone to come to me?
So both. If there's someone, the providers are worried about or that they deem high risk when they come in, and it can be acute or it can be chronic, they will contact me and I will contact the patient. Or, we have patients that call the clinic and they've only been in a couple of times or never been in, and they don't even know that we have this program, but they reach out to us. And as soon as they call, they'll send them to me, and we figure out, hey, they need a home visit. We try to get them to come into the clinic for their first visit. But after that, if we deem them, they're homebound and they can't get out, we go out and we see those patients, and we try to schedule those every 2 or 3 months. If they need labs, anything we try to do in the home.
And you mentioned food. So food insecurity is a part of the community too, but it's not just blood pressure monitoring. This also carries into medication management, education. So it's really an in-home care model.
Yes. So, really anything they need. We have, Feed Local here in DeQueen that is a nonprofit organization, and, they keep churches stocked with food. They kind of, they'll help with our food pantry for chronic care management. That's another, we have that we can go to here in town to help with people. But, we do everything. We have transportation, and that's also me. If they need a ride, and we try to exhaust churches and family members first. But if that's not possible, then, we have a waiver they sign. I go out, they sign the waiver. I transport them to the clinic and then take them back home after. If they need medicine, we will stop by the pharmacy on our way home and grab that if the pharmacy don't deliver. We are fortunate here, and we have a couple of pharmacies that do deliver to patients.
And have you seen measurable improvements in health outcomes among the patients that you serve?
Yes, we have. The med boxes, I feel a lot of those patients, they have a hard time reading their medicine bottle, or they don't understand. They don't have family members that take care of them. So I go out and I fill those boxes, but a lot of those patients, they won't take their medicine, and so that keeps them out of the hospital. It keeps them from having issues and having to come back into the clinic, and kind of manages their chronic problems that they have. So we have seen, quite a bit of improvement with that.
What does your care team look like? How do you coordinate with the providers within Dr. Walker's clinic to ensure continuity and documentation of care?
So, we're there 7 to 7, 7 days a week. There's always a provider there that I can call and communicate with. I have Devin Russell, which is a nurse practitioner at our school-based clinic, but she also does all of our telehealth. So if there is not a provider in the home, then I will assess the patient and telehealth back with her so that we can get the patient seen. We have one EMR that all of our documentation goes into. And so every provider at the clinic can see everything I do. I can see everything they do. And we kind of stay on the same page everything's right there so we can all access it.
What are some of the biggest challenges you faced in maintaining or scaling this level of personalized care in a rural environment?
Really, it's the ones that go to the ER and are used to just going to the ER for those kinds of issues, trying to retrain them and to understand that we're 7 to 7. You can call. I have a direct number to me. They can, call me and contact me instead of, going to the ER. Like, I can just teaching them that we do have this and that it is there for them to utilize, and that we can come out and fix those issues or adjust meds and, communicate with the provider out of their home.
And from a reimbursement or funding perspective, how does this currently supported? Are there value-based models, grants, or different billing mechanisms in place?
Well, right now, as far as our food pantry, we do all of that in-house. Transportation is the same way. It's just we don't do enough that it's just, we're overwhelmed with it. Right now, we can manage the population that we have. So we manage most of it or all of it inside our clinic. And then when we go out and see the patient, do the home visit, it comes back to the provider. So we're either doing an office visit or a nurse visit, and we're able to document those things in their chart and just bill accordingly to what the service is.
So for other clinics, health providers looking to implement or expand similar chronic care outreach, what would be your recommendations?
Start small. Everybody has 10 or 15 high-risk patients that they can pick out and start to manage. And then once you get that down and you can manage those patients and you start noticing the decrease in the ER visits or them calling several times a day, you're able to get those patients managed and get better care, then you can grow from there and then grow your team. It started out as just me and one other provider in the chronic care management program. And just this past year, we've added one more person because we've gotten big enough. We contact all 380 of these patients every month. So we're either contacting them at least once a month. And then some of them, when they need us, they know to call us, and they'll call us directly and we'll take care of whatever it is they need.
Well, Brittany, thanks so much for talking to us today about this important information and really amazing effort that your clinic and this program is doing for the residents of Sevier County. Thank you.
Thank you so much for having me.
And that's it for AFMC TV. Have a great day. Thanks for watching.